Juvenile idiopathic arthritis results from abnormally regulated immune responses that lead to inflammation of joints, surrounding tissues, and other organs. Often, non-rheumatic diseases that can cause similar features need to be excluded during evaluation. Rheumatoid arthritis in children may present in one of three forms: a systemic onset arthritis, that is Still's disease, or polyarticular onset arthritis, that is 5 or more joints, usually of both large and small, affected, or polyarticular onset arthritis, that's fewer than 5 of mainly large joints affected, in either of which may be rheumatoid factor positive or negative. Those with positive anti-nuclear antibodies test need regular eye checks for uveitis. And for this condition, it is mandatory for arthritis to be present for at least 6 weeks for the diagnosis to be made. Causes: autoimmune diseases. The symptoms are morning stiffness, joint pain, painful red eyes, rash, joint swelling, and fever. The signs that are usually elicited are swollen, warm joints, restricted range of joint movement, systemic onset, fever, macular rash, hepatosplenomegaly, lymphadenopathy, serositis, for example, pericardial effusion, and red eyes. Investigations are FBC, ESRB, creatinine, LFTs, liver function test, C-reactive protein, rheumatoid factor, anticyclic citrullinated peptide antibody, antinuclear antibodies, X-ray of affected joints, slit lamp examination, and other tests as determined by specialists. So the main treatment objectives are to control pain and inflammation, to prevent deformities and growth retardation, to control extra-articular complications, to minimize drug side effects, and to optimize chance for normal social development. So non-pharmacological treatment: physiotherapy, psychotherapy, occupational therapy, diet therapy, and patient counseling. For pharmacological treatment, to control pain and inflammation, first-line treatment, we give ibuprofen oral. In children 6 to 12 years, we give 200 to 400 milligrams 8 hourly as required. 1 to 5 years, we give 100 to 200 milligrams 8 hourly as required. 3 months to 1 year is not recommended. Or you can give indomethacin oral. In children more than 14 years, 25 to 50 milligrams 8 to 12 hourly, the maximum of 200 milligrams per day. And 2 to 14 years, we give 500 micrograms to 1 milligram per kilogram 12 hourly, with a maximum of 150 milligrams per day. In less than 2 years is not recommended. Or you can give naproxen oral. In children more than 5 years, 5 to 7.5 milligrams per kilogram 12 hourly, with a maximum of 1 gram per day. Less than 5 years is not recommended for this condition. The second line treatment, you give cholecalciferol oral in children more than 2 years with a weight more than 25 kilograms. Give 100 milligrams 12 hourly. And more than 2 years with weight between 10 and 25 kilograms, give 50 milligrams 12 hourly. Less than 2 years is not recommended. The long-term use of NSAIDs like diclofenac, naproxen, and ibuprofen, that is for more than 2 weeks, may cause renal impairment and gastritis. Refer after 2 weeks of NSAIDs use. For steroid therapy to control inflammation, you deal with it appropriately, and then you give prednisolone. So you give the ibuprofen or indomethacin or naproxen or the cholecalciferol appropriately, and then you add prednisolone oral in children 0.5 to 2 milligrams per kilogram daily, or 12 hourly, with a maximum of 60 milligrams per day. If your symptoms do not improve after 6 weeks of steroid use, you treat as a chronic case. And for treatment of chronic symptoms, first line treatment, you give intra-articular corticosteroid injection. With this, you have to consult a specialist. Then you give methotrexate and also etanercept. This one you have to consult a specialist, and infliximab, and also adalimumab, and finally you can give anakinra. So all these medications you have to consult a specialist. Referral criteria: so refer all suspected cases to a pediatrician or a rheumatologist.